Hello everyone, welcome to my today's lecture about psychiatry. My name is Dr. Lin. Today we are going to talk about substance-related disorder. The substances include the classes of CNS depressants, stimulants, hallucinogens, and others. The depressants group include alcohol, sedated, hypnotic, or anxiolytic, for example, Benzodiazepam, opioid, inhalants in the form of toxic gases from glues, fuels, paints, and other volatile compounds. The stimulant groups include cocaine, amphetamine, caffeine, and tobacco. Cocaine may come with powder form or crack cocaine to be smoked. Amphetamine group includes methamphetamine. The names are crystal meth, ice, crystals, crank, MDMA, ecstasy. So for caffeine, we all know that caffeine is the most widely used psychoactive substance in the world. In America, more than 80% of the adults consume caffeine in the form of tea, coffee, or caffeinated soda like cola, Coke, energy drinks, etc. And tobacco, which is nicotine. For hallucinogens, include phencyclidine, cannabis, and other hallucinogens, which are LSD and MDMA. So MDMA is somewhat unique because in DSM-5, MDMA is classified into hallucinogens, but it has a strong action as the similar to amphetamine, stimulant effect. And other addictive disorders which are not included in the lecture are non-substance related addictive disorder, for example, gambling disorder. So before we go further, I would like to explain that substance-related disorder can be categorized into two different groups, which are substance use disorder and substance-induced disorder. So now we are going to talk about substance use disorder. The diagnosis of a substance use disorder can be applied to all 10 classes included I above mentioned, except caffeine. So an individual must have two of the following 11 features occurring within 12-month period. So we can organize into 4 groups. The first criteria grouping is impaired control. So number 1 criterion is that the individual must take the substance in larger amounts or over a longer period than was originally intended. And criterion 2, the individual may express a persistent desire to cut down but fail to do so. And criterion number 3 is spending a great of time to obtain the substance or use the substance or recover from its effects. And craving, which is criterion 4. Craving is an intense desire or urge for the drug or substance that may occur at any time, but is most likely occur when and in an environment where the drug previously was obtained or used. So craving has been shown that it involves classical conditioning, which is associated with the activation of specific reward system in the brain. The second group is social impairment. So the recurrent substance use may result in a failure to fulfill major rule obligations at work, school, or home, which is criterion 5. And 6 include the individual may continue substance use despite having the persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. And 7 Important social, occupational, or recreational activities may be given up or reduced because of the substance use. And the criterion 8 to 9 goes to 8 and 9 goes to risky use, which is that group. This may take in the form of recurrent substance use in situations in which it is physically hazardous. And 9, the individual may continue substance use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. And the last group is pharmacological criteria, which include tolerance and withdrawal. So what is tolerance? Tolerance is the requirement of a markedly increased dose of the substance to get the desired effect, or it's a markedly reduced effect when the usual dose is consumed. And withdrawal. Withdrawal is a syndrome that occurs when blood or tissue concentration of a substance decline in an individual who had maintained prolonged heavy use of the substance. So when we develop withdrawal symptoms, the individual is likely to consume the substance to relieve the symptoms. That is called withdrawal. So substance use disorders can occur in the form of from mild to severe forms. Generally, mild substance use disorder is suggested by the presence of 2 to 3 symptoms, moderate by 4 to 5 symptoms, and severe by 6 or more symptoms. So now we have talked about the generic diagnostic criteria for substance use disorder, which we can apply to the 10 different substance use. Now I'm going to talk about substance-induced disorders, which include intoxication, withdrawal, and other substance-induced mental disorders. So I would like to start with alcohol intoxication, which this is the page from DSM-5. And the diagnostic criteria include one or more of the following signs and symptoms. So let's focus on the criteria, diagnostic criteria, the part C. Okay, so one of the more following signs and symptoms developing during or shortly after alcohol use, which includes slurred speech, incoordination, unsteady gait, nystagmus, impairing attention or memory, or stupor or coma. And the alcohol intoxication, this criteria is similar in the intoxication for sedative hypnotic, the benzodiazepine groups, because alcohol and benzodiazepine, they are in the same class, which is a CNS depressant. So they have their very similar, the same diagnostic criteria. And withdrawal. Again, this criteria is the same in sedative hypnotic withdrawal criteria. Okay, so alcohol withdrawal. To diagnose the alcohol withdrawal, the patient has 2 or more of the following, developing within several hours to a few days after the cessation of alcohol use. So the signs and symptoms include autonomic hyperactivity, examen sweating or pulse rate greater than 100 beats per minute, increased hand tremor, insomnia, nausea or vomiting, transient visual or tactile or auditory hallucinations or illusions, psychomotor agitation, anxiety, or the severe form is the generalized tonic-clonic seizures. So we can differentiate the alcohol withdrawal classification by stages depending on the time of their last drink and their respective symptoms. So the stage 1 is a mild withdrawal form, which one individual stop the drinking, and then after 6 to 8 hours, the mild tremor, anxiety, and nausea can develop. And then stage 2 occurs from 12 to 24 hours after the last time of drinking, and the symptoms include tremor, agitation, insomnia, and hallucinations. So this phase is we call it alcoholic hallucinosis, because hallucinations can occur in stage 2. And the stage 3 start from 12 to 48 hours after the last drink. So seizure can occur, withdrawal seizures, and more severe forms of stage 2. And the stage 4, which can occur from 2 to 5 days after the last drink. And this is the very severe form. We call it delirium tremens. It has a 5% mortality. And it is characterized by unstable vital signs, confusion, agitation, fever, tachycardia, hypertension, diaphoresis. The management of alcohol intoxication is just conservative treatment, which includes IV vitamin B1, because the alcoholics tend to have the vitamin B1 deficiency, which has serious complications like Wernicke-Korsakoff syndrome or dry and wet beriberi. So we need to give the vitamin B1 in addition to the dextrose, because they tend to have the hypoglycemia and fluid management. For alcohol withdrawal, we give the diazepams, because during the alcohol withdrawal phase, the patient is the vital signs are hyperstimulated, right? Hyperexcited. So we gave the diazepam. So usually the longer acting diazepam like chlordiazepam are being used. But for patients with impaired liver function, especially in chronic alcoholics who have impaired liver function, we have to use the benzodiazepine groups which do not pass the liver for metabolism, which are lorazepam, oxazepam, temazepam. So lorazepam is widely used for patients with impaired liver function. So this is the management for alcohol intoxication and withdrawal. And the treatment for alcohol use disorder is more complicated. It includes pharmacological treatment. The options are naltrexone and ecambroxate, gabapentin, topiramate, and disulfiram. And the psychotherapy, the various psychotherapy options are available, which are found to be highly effective for alcohol use disorder, include CBT, cognitive behavior therapy, and community reinforcement approach, CRA, and motivational interviewing, MI, and peer support groups, for example, Alcoholics Anonymous, AA meeting. So for naltrexone use, we have to check the liver function test as a baseline and then checked after 1 month, because it can elevate the liver function, liver enzymes. So if the liver function are elevated more than 3 times, then naltrexone should be stopped. And naltrexone is found to be the first line medications used in alcohol use disorder. The management for benzodiazepine intoxication is the same as alcohol, which is a conservative treatment. And there is a medication called flumazenil, which is a benzodiazepine receptor antagonist, but it is rarely used because it can precipitate seizures. And for withdrawal, is a similar treating the alcohol withdrawal. So means that we have to give the benzodiazepine to the patients with withdrawal symptoms. For the benzodiazepine use disorder, the treatment include that we have to taper the medications with the aim of abstinence or consideration of maintenance therapy with a harm reduction strategy approach. For the tapering phase, the patient may benefit from cognitive behavior therapy. So now that we have covered about alcohol and sedative, hypnotic, and anxiolytics groups, so another depressant groups include opioid, so which is a significant topic. So for opioid intoxication, the diagnostic criteria from DSM-5 includes the pupil constriction and one or more of the following signs and symptoms, which include drowsiness or coma, slurred speech, impairment in attention or memory. So it is very important to notice and to diagnose the opioid intoxication. So on the other hand, opioid withdrawal symptoms include resting pulse rate, sweating, restlessness, pupil dilation, bone and joint aches, runny nose, tearing, GI symptoms, tremor, yawning, anxiety or irritability, and goose flesh skin. So we can use this kind of scale, which I just mentioned is clinical opioid withdrawal scale, which has the 1 to 11 signs and symptoms. Each item goes from 0 to 4 or 5 points and up to a total of 48 points. If we sum up the points and then get the 5 to 12 points, then we define as mild withdrawal, or 13 to 24 to moderate, and moderately severe is 25 to 36, and more than 36 points, which is the severe withdrawal. Here, the major issue is opioid overdose, which is lethal. So when a patient is suspected to have the opioid overdose, which the presented with signs and symptoms of opioid overdose, then we must give the naloxone via intravenous or intramuscular or subcutaneous or intranasal route, whichever is readily accessible at that moment, which is a life-saving treatment. And for opioid withdrawal, then we need to just give the symptomatic treatment, because opioid withdrawal cannot result in death. For opioid use disorder, aka opioid dependencies, so we need to give the opioid replacement therapies, most commonly with methadone and buprenorphine naloxone combination, which is in the name of Suboxone. Now, Suboxone is more commonly used than methadone. And the effective psychotherapy includes motivational interviewing, case management, psychoeducation, and peer group supports, like in alcohol use disorder. Now, the last substance in the depressants group is Inhalant. For inhalant intoxication, the signs and symptoms of inhalant intoxications are dizziness, nystagmus, incoordination, slurred speech, anesthetic gait, lethargy, depressed reflexes, psychomotor retardation, tremor, generalized muscle weakness, blurred vision or diplopia, stupor or coma or euphoria. So mostly are the effects of CNF depressants. And the treatment of inhalant intoxication is self-limiting. So we don't need to give any treatment about that. Okay, now I would like to move to the second group of substance, which is the stimulant intoxications. Okay, so the first group would include the cocaine, mainly the cocaine and amphetamine. So when a person is being intoxicated with stimulants, with either amphetamine or cocaine or other stimulants, then individual must have 2 or more signs and symptoms described here, which are the effects of stimulants. So you can imagine the patient would have tachycardia, the pupil dilatation, high blood pressure, and perspiration, nausea, vomiting, and the evidence of weight loss, especially if the patient is chronically using the stimulants. And the psychomotor agitation, or the chest pain, because especially with cocaine, it can induce the tachycardia and elevated hypertensive crisis, as well as a coronary vasospasm. So it can cause the angina or cardiac arrhythmias. And for CNS effects, confusion, seizure, dyskinesia, dystonia, and coma. For withdrawal, so for stimulants withdrawal is the opposite of the intoxication phase. So means that the symptoms will include fatigue, because the patient no longer have the energy which is provided by the stimulants. So the patient may experience fatigue, vivid and unpleasant dreams, insomnia because of the dreams, or maybe hypersomnia, and increased appetite. Increased appetite because while a patient individual is using stimulants, he has a decreased appetite, and then during the withdrawal he regains the appetite. and psychomotor retardation or agitation can also occur. For the treatment of psychostimulant intoxications include Benzodiazepam to control the agitation and seizure. And for cocaine-induced vasoconstrictions, like as I mentioned, hypertensive crisis, tachycardia, angina, then we can give alpha blocker like phentolamine, phenolxifensamine, or mis-alpha beta blocker such as labetalol. But we cannot use beta blocker alone in stimulant intoxications because it can lead to the end of both alpha action. Alpha action is vasoconstriction, so it will expose the patient into the danger of the widespread vasoconstriction, and then heart failure can occur. And the strongest evidence-based approach for the treatment of stimulants use disorder remains contingency management interventions. So, which means that the patient is given like a gift card or voucher or chance to win a prize. It's a reward if he or she stay as sober, stay as if the urine drug screen is come back negative, and then we give the prize. We give the patient the prize so that he get the motivation. So this is the only evidence based approach for the treatment of stimulants use disorder. No pharmacological treatment is being found to be effective at this moment. Okay, now we are going to nicotine withdrawal, which are the very similar the diagnostic criteria with other stimulant withdrawal. So it includes the irritability, frustration or anger, anxiety, difficulty concentrating, increased appetite, restlessness, depressed mood, and insomnia. So for nicotine, the smoking cessation is a key. The combination of psychotherapy, especially motivational interviewing with pharmacology, is better than doing either treatment alone. So for medications, for pharmacological treatment, the most effective to the least effective medications are varenicline, which is the partial antagonist of nicotine receptors, and followed by bupropion, which is their NTRI, noradrenaline, norepinephrine dopamine reuptake inhibitor, and nicotine replacement therapy. But we start to use with the nicotine replacement therapy as the first line, and then followed by non-nicotine pharmacotherapies such as varenicline and bupropion. But the patient is a heavy smoker or there are withdrawal symptoms despite the nicotine replacement, then we can consider adding the non-nicotine pharmacotherapies. Here, I would like to mention that if the varenicline is used in conjunction with nicotine replacement therapy, it's better than varenicline alone. And it's important to note about bupropion is that bupropion can lower the seizure threshold in patients. So we cannot use bupropion in patients with history of seizures as well as in patients with eating disorders. And another stimulant substance, and the worst widely used substance is caffeine. So let's look at the caffeine intoxication. So especially the caffeine intoxication occur typically with a high dose in excess of 250 milligram, and the 5 or more symptoms, which includes restlessness, nervousness, excitement, insomnia, flat face, diuresis, GI disturbance, muscle twitching, so rambling flows of thoughts and speech, tachycardia, cardiac arrhythmia, and inexhaustibility and psychomotor agitation. So which are the overall the stimulant effects of caffeine. For withdrawal, so we all know that especially those who are regularly taking coffee or tea, then we in some point of time we have already experienced the withdrawal of caffeine. So in my experience, I also have headache and fatigue or drowsiness. I don't feel good if I get withdrawal from caffeine, if I don't drink coffee the whole day, and the next day I will have the headache, or maybe not even the whole day, just the morning and after early afternoon. Then I am starting to have these symptoms. So headache, fatigue, dysphoric mood, depressed mood, or irritability, difficulty concentrating, and flu-like symptoms. Now I am moving to another my third category of substance, which are hallucinogens. So I took this portion from the book of Firstaid for USMLE, so which summarize the symptoms, signs and symptoms of intoxications as well as withdrawal for hallucinogens. So let's start with lysergic acid diethylamide, LSD. So for LSD intoxication, the patient may experience, so as given the name hallucinogen, so they are basically having hallucination. For LSD, they may have the visual or auditory hallucination, and in addition to that, they experience depersonalization, anxiety, paranoia, and can even have psychosis, and they can have their flashback. For marijuana, aka cannabinoids, which intoxications include euphoria, anxiety, paranoid delusion, and the unique symptoms of marijuana intoxication is a perception of slow time and impaired judgment, social withdrawal. And when a patient is taking marijuana, then he or she is having the increased appetite. When it becomes withdrawal, then the appetite will reduce conversely. And another significant feature is conjunctival injection. Then hallucination is the symptoms of intoxication of any hallucinogens. So another substance is MDMA, ecstasy, that I have mentioned earlier, that ecstasy MDMA is unique in the way that it is categorized into the hallucinogens in DSM-5, although it has the very similar effects of stimulants such as amphetamine. So here they call it hallucinogenic stimulant, causing the euphoria, hallucination, disinhibition, hyperactivity, increased thirst, and the symptoms is bruxism, so teeth grinding, and distorted sensory and time perception. And the life-threatening effects include the stimulant effects of like amphetamine, hypertension, tachycardia, hypothermia, and hyponatremia, because MDMA can induce the SIADH state. So hyponatremia can result, and it can also cause serotonin syndrome if a patient is taking other serotonergic medications, like, for example, SSRI. And phencyclidine. Phencyclidine is a unique hallucinogen because it can lead to violence and impulsivity and psychomotor agitation, and the significant feature is nystagmus and tachycardia, hypertension, and it has the effect of analgesia, pain relieving effect. And it can also lead to psychosis, delirium, and seizure. So in phencyclidine overdose, the trauma is the most common complication because the patient is very violent. So for withdrawal phase, we can easily see in marijuana withdrawal, the patient will have the decreased appetite and depression and insomnia and restlessness. In MDMA, it is the reverse form of stimulant effect. So depression, fatigue, change in appetite, difficulty concentrating, and anxiety. For hallucinogens, the management are not specific. So for intoxication, the treatment should be directed at the primary presenting problems or organ system issues. So means that conservative and it tend to be symptomatic treatment. And the routine clinical support and substance use disorder psychotherapy, such as motivation and interviewing, are only recommended therapies. So now that we have covered the majority of substance-related disorder, including substance use disorder and its general diagnostic criteria from DSM-5, and also the substance-induced disorders, we have talked about the intoxication signs and symptoms, the withdrawal signs and symptoms, and as well as its their respective management. And the last substance-induced disorder component is the substance-induced mental disorder. So the different substances can induce various psychiatric symptoms, including depression, psychosis, mania, sleep disturbance, sexual dysfunction, cognitive impairment, delirium, anxiety, during the different phases of intoxication or withdrawal. So this table summarizes the DSM-5 recognized syndromes and the diagnosis. So I would like to leave you with this table. Thank you so much for your attention, and see you in the class.